All right. Well, good afternoon, everyone. I'm going to give everybody a moment to join us. At least it's the afternoon here in Washington, D.C. Thanks for joining us for our weekly webinar. Last Friday we took a bit of a break because we just finished our national annual summit on health disparities, which I'm hoping a lot of you got the opportunity to meet and greet and visit or watch online. That will be available on our YouTube channel really soon. So all the programs from the opening to the awards dinner will be available, and with much of the contact information of the individuals that participated. Much like the summit, we did a lot of discussions like we do here every Friday, where we take on an issue and we talk through it. Today, we're going to talk about reform to Medicare Advantage, and it's going to be led by our very own Ashira Vantries. Ashira, actually, she didn't moderate a panel this year, but she's actually been participating in the summit for some time and hosted a program last year. So we have all the confidence in the world that she will continue to do a great job and do it on this very platform today. Before I turn it over to her, however, I want to just give you a couple little brief announcements. One, some housekeeping things. If you have any questions that you want the moderator, if you want her to ask the panelists, please put it in the Q&A box, which is listed below. And then if you just have some side comments or commentary that you want to share with everybody that's participating, put it in the chat box to your right. But that's all I have. And so without further ado, I turn it over to Ashira.
Thanks, Brandon. And I'll just share my screen so we can all be looking at this deck. All right, can everyone see that? Perfect. Well, hi, everyone. Like Brandon said, depending on where you are, good morning or good afternoon. Thank you for joining us for today's webinar on Medicare Advantage reform. Also, thank you to NMQF for hosting this webinar and providing us this opportunity to talk about the need for Medicare Advantage reform and Medicare reform and upcoming opportunities for engagement on this issue. Like Brandon said, my name is Ashira Vantries and I serve as counsel at Aimed Alliance. If you're not familiar with Aimed Alliance, we're a nonprofit health policy organization whose mission is to protect and enhance the rights of healthcare consumers and providers. And I'm thrilled to be here today with Michael Ward, the Vice President of Public Policy and Government Affairs at the Alliance for Aging Research, and Dr. Jeannie Fulgenstein-Bennick from KFF. And I'll just introduce them briefly, but I'm sure their bios do not do justice to all the great work they're doing. So first, Michael serves as the Vice President of Public Policy and Government Affairs at the Alliance and leads advocacy efforts with Congress and federal agencies. Michael convenes multiple coalitions, elevating the patient voice and advancing policies supporting affordability, access, equity, and funding for healthcare research. His work also focuses on elevating the needs to incorporate the experience of older adults in outcome research and value assessments. Previously, Michael worked at Premier Inc., the American Hospital Association, and Avalier. Michael received his BA from Vanderbilt and his MS from Carnegie Mellon University. Thank you for joining us, Michael. I also have the privilege of introducing Dr. Fulgenstein-Bennick with KFF. Dr. Bennick is an Associate Director for the Program on Medicare Policy at KFF. She focuses on providing analysis is used to develop data-driven approaches to pressing national health policy issues, including the role of Medicare Advantage, the delivery and financing of care for people who are eligible for both Medicare and Medicaid, Medicare spending trends, and efforts to reform provider payment. Her work has been published in Health Affairs and cited by the Washington Post, the New York Times, and USA Today, among others. She has also testified on health policy issues before Congress. Thank you both for joining us today. So just a brief overview of what today's conversation is going to look like. I'm going to provide a quick summary of what the Medicare and Medicare Advantage programs are. Then we're going to hear from Dr. Fulgenstein-Bennick on the Medicare payments, how the federal government pays for Medicare. And then we'll hear from Michael about some of the unintended consequences of the cost-saving measures implemented in the Medicare program. And then we'll open it up to a panel discussion and a Q&A from the audience. So like Brandon said, if you have any questions throughout the presentation, please drop them in the Q&A and we will address them at the end. So like I said, I'm just going to briefly kind of highlight what the Medicare program is to lay the foundation for today's conversation. And I think the first thing that we always need to talk about is who are the individuals being impacted by these programs and benefiting from these programs. So within the Medicare space, there's two ways to qualify for Medicare. So you can be over the age of 65 or you can have a qualifying health condition such as ESRD, a disability, or ALS, and you can qualify if you have one of those conditions for Medicare at any age. And so as we're talking about Medicare Advantage and Medicare reform in today's conversation, I really want us to make an effort to keep these individuals in mind, because these are the people who are being impacted by these programs and who will benefit from us fixing some of the gaps within these programs. So what is Medicare? Medicare is federal health insurance that is broken down into 4 parts to provide comprehensive coverage. And I'll just quickly go over what those 4 parts are. So the first 2 parts, Part A and Part B, is what we often refer to as original Medicare or traditional Medicare. And this includes services like inpatient hospital and outpatient care. And so this can include things like, for Part A, hospital care, nursing facilities, hospice, lab tests, and home health care, while Part B covers more of the medical insurance side. So this is things like the services that are needed to diagnose or treat a condition, durable medical equipment like canes or crutches, and it also covers some preventative services like vaccines and cancer screenings. Part B coverage also does cover certain prescription drugs, but only prescription drugs that have to be administered in a healthcare provider's office or in an outpatient hospital facility. So it's not all types of prescription drugs. It's just a very narrow group of prescription drugs. And so if someone does need prescription drug coverage, that's not those types that are administered by a healthcare provider, they can purchase what's known as Part D coverage, which is a standalone plan that they can purchase for prescription drug coverage. But the downside of traditional Medicare is it doesn't cover other services like vision care or hearing care or dental care, which some older individuals may also need coverage for. So for individuals who need those additional services, they have the option to purchase a Medicare Advantage plan, which is also known as Medicare Part C. Medicare Advantage plans are required to cover all the benefits and services in Part A and Part B, and can also offer additional coverage like the dental care, the eye care, and hearing coverage for things like hearing aids and fittings, which can be really important benefits for older adults. Medicare Advantage plans also can include that second category of prescription drug coverage, so those non-physician administered drugs, as part of the package, so an individual wouldn't have to purchase just a standalone Part D plan as they would if they're enrolled in traditional Medicare. So those are kind of some of the big picture differences between the Medicare and the traditional Medicare program. And there's also some logistical differences that I want to highlight. So how these programs are paid for with Dr. Fulgenstein-Bennett is going to do a much better job of explaining this than I am, but just kind of the overview is that for original Medicare, the federal government pays directly for those services through a fee-for-service reimbursement structure. Whereas under the Medicare Advantage program, the federal government pays a fixed rate per Medicare Advantage beneficiary to the plan. So the payment structures are slightly different, and there's also a difference in the type of providers that you can see. So original Medicare beneficiaries can go anywhere that accepts Medicare, whereas Medicare Advantage beneficiaries can have a narrower list of where they can go. And there's also different coverage rules that apply to the services and treatments under Medicare Advantage and original Medicare. And just one that I want to highlight is step therapy in Medicare Advantage and Medicare. So in 2012, CMS issued a memo stating that Medicare Advantage plans could not use step therapy unless it was also used in original Medicare. And their justification was that Medicare Advantage is supposed to be providing the same benefits as original Medicare. So they shouldn't be implementing any policies that make it more restrictive than original Medicare. But in 2018, CMS reversed this decision, stating that MA plans could now use step therapy in Part B drugs and services, so long as those step therapy policies did not create an undue access barrier for beneficiaries. But undue access barrier is kind of general, and so it can be difficult to establish what type of policies are actually constituting an access barrier. And so the reason I think this background is important ahead of today's conversation is because one of the things that we really want to look at is, are Medicare Advantage beneficiaries and traditional Medicare beneficiaries receiving the same types of benefits? Because I think with step therapy, it really does raise the question is, to get access to one medication, a Medicare Advantage beneficiary has to go through the step therapy policy, but an original or traditional Medicare beneficiary doesn't, then is one individual experiencing delays as a consequence of the step therapy policy where the other isn't? And this is also, I think, an important conversation to have now because we're seeing a growingly diverse population entering the Medicare Advantage market, with research from KFF in 2021 finding that Black, Hispanic, and Pacific Islander beneficiaries are more likely to enroll in MA compared to white beneficiaries. So we want to ensure that as these programs are growing and they're continuing to use the utilization management tactics, that these tactics aren't contributing to health disparities or perpetuating health inequities. So I think today's conversation is going to be really helpful in understanding what we know about how the current program works and what we know about what are some of the potential consequences we see from the future reforms that are coming to this space. So with that, I'm going to turn it over to Dr. Fulgenstein-Bennick, who is going to talk about what we know about Medicare Advantage at the moment, what the data tells us, and what the questions we should be asking about these programs.
Hi, everyone. Thank you so much for joining, and thank you for having me today. Before I start, I just want to tell you a little bit about KFF. We are an independent source for health policy research, polling, and journalism. And our mission is really to inform policymakers, the media, the health policy community, and the public in a nonpartisan way. So we don't take positions on policy issues. We really are here to help inform the discussions that are happening. And I hope that my presentation today will be helpful to that end. Go to the next slide. So as Ashira went over, I'm going to just do a little bit more briefly about what Medicare Advantage is. So this is an option for Medicare beneficiaries. You can choose to enroll in traditional Medicare and get your Part A and Part B benefits that way, or you can choose a Part C plan. These are usually HMOs and PPOs, and they've been in the program for quite a few decades, but have been known as Medicare Advantage since 2003. It covers Medicare pays private insurers a fixed amount per person, and they adjust this amount for somebody's health risk to provide all Part A and Part B covered services. And exactly how much a plan gets paid is affected by the county in which the plan is operating, and what traditional Medicare spends in that county, and the contract that a plan is a part of, what their star rating is. And star ratings are intended to measure quality, though many people argue that they don't do a very good job at that. Beneficiaries can choose traditional Medicare or Medicare Advantage when they first go into Medicare, and each year in the annual enrollment period. Though Medigap supplemental insurance in traditional Medicare is not guaranteed issue outside of your first initial enrollment period, except in 4 states. And the reason this is important is traditional Medicare can have relatively high cost sharing, meaning when you go to the doctor, you can pay, after a small deductible, 20% of what the Medicare price is. And if you don't have any insurance to help with this 20% and you're on chemotherapy, that can actually end up being quite expensive. So most people who are not dually eligible for Medicaid also buy a Medigap policy. And this comes with somewhat high upfront costs in terms of premiums, but it eliminates most of your cost sharing, or has the potential to, depending on which plan you choose. So if you decide initially you're going to go into Medicare Advantage, which you can usually find a plan in your area that has no supplemental premium outside of your regular Part B premium, which is why this is pretty attractive. You can get your dental, your vision, your hearing, plus an out-of-pocket limit by choosing a Medicare Advantage plan. So you go into it, you decide, oh, I actually don't like this restriction of networks only being able to see certain providers, or some of the utilization management tools that the plan's using. Prior authorization is one I will talk about. If you decide you want to switch back into traditional Medicare, you might have a very difficult time if you have a chronic condition to find a plan. Either you will be subject to underwriting and have to pay a much higher premium, or it's possible you won't be able to find one at all. And so the out-of-pocket expenses can be quite limiting for people. Medicare Advantage does not have separate financing. People who are enrolled in Medicare Advantage plans still pay the same monthly Part B premium. The standard monthly Part B premium is about $175 this year. Plans can impose additional premiums if they have costs that exceed the maximum amount Medicare is willing to pay, as well as for prescription drugs and non-Medicare benefits like dental, vision, hearing. I will say most plans do not, and virtually everybody has a Medicare Advantage plan with prescription drug coverage that does not require them to pay an additional premium each month. Next slide. So just sort of set some context. I don't know how familiar people are with some of the changes that have gone on recently with how Medicare Advantage plans are paid. There's been a lot of pushback from industry about how this is going to ruin their financial prospects and ability to offer plans in the market. And I want to put that in context. Over the next decade, Medicare Advantage plans are projected to receive about $7 trillion in payments from the federal government. The changes that have been made by CMS don't even move this line on this chart. So for some plans it might, it's definitely have a bigger impact than others, but for many it will not. And just something I don't have on this slide, but is also I think a good data point, is over 50% of Medicare beneficiaries are in Medicare Advantage plans. So this does affect a lot of people, the things we're going to be talking about today. And just in terms of thinking about the market, the average beneficiary has 43 Medicare Advantage plans to choose from. So it's very robust. There are a lot of options. There's a lot of choice. And so if you hear that some of these changes are going to be just devastating, I think it's probably unlikely. Next slide, please. So going into the payment just a little bit more, I think one thing to take away from all of this is that the Medicare Advantage program is not designed to provide savings to the federal government. So when private plans were first introduced into Medicare, there was an argument that allowing managed care to come in could lower federal spending for Medicare, and that has never been the case. And part of the reason that that's not the case is just the payment formula is not set up to pay less. In half of the counties, the benchmark, which is the amount that Medicare, the maximum amount Medicare will pay, is above traditional Medicare spending, and that is just the formula. And then there are other things that contribute to higher payments. So one that I will get into a little bit here, but definitely will be happy to answer more questions about, are favorable selection and coding intensity. So on average, when plans submit their bid to CMS to say how much it's going to cost them to cover an average Medicare beneficiary, before we consider favorable selection or coding intensity, those bids are about 82% of the cost of traditional Medicare. But MedPAC has done an analysis, and they do this every year, and their most recent analysis shows that once you consider favorable selection and higher coding intensity, their costs are actually just above. And this is just for Part A and Part B services. So the argument that they're more efficient, I think we should maybe receive with a little bit of skepticism. And then on top of the spending for Part A and Part B benefits being even or maybe a little higher on average, plans get to retain the difference between the benchmark and the bid, a certain share of that depending on their star rating. On average, it's $2,300 per enrollee this year. And they use that to lower cost sharing, pay for extra benefits, reduce the Part B or Part D premium. All of those things are arguably potentially very helpful for enrollees. Something I'll end with is data gaps. We don't really know how beneficial they are, though CMS is, I think, trying to take some steps to improve the data in that area. But given the magnitude of this spending, I think asking questions about how valuable it is is something that is, warranted. Overall, the payments that plans are getting per enrollee are 122% of what Medicare is spending for similar beneficiaries in traditional Medicare. And one of the main reasons for this, outside of just the payment methodology, is first favorable selection. So people with the same health sort of status, the same types of chronic conditions, those who have lower spending for whatever reason tend to enroll in Medicare Advantage. So when estimating what their costs are, the current methodology actually overestimates and gives plans an adjustment that is higher than is probably necessary to cover their costs. And then the other thing that goes into this is coding intensity. So the payment that a Medicare Advantage plan receives is adjusted based on somebody's risk score, which is a number that is calculated based on their diagnosis history. And so if the plans have an incentive to document very comprehensively any diagnosis that somebody has, when comparing these people to traditional Medicare just doesn't have that same incentive for a provider to get paid in traditional Medicare. They only have to put a diagnosis that justifies that particular service. And so we see a difference between the two populations that ends up making Medicare Advantage enrollees look sicker than they are, or than they would be coded as being if they were seeing providers under the traditional Medicare system. Next slide. And in recent years, the impact of favorable selection and upcoding is the sort of shorthand for this coding effect has increased, so that this year it's at $83 billion. So this is quite a lot of money that is going to Medicare Advantage plans. Next slide. So going back to like why somebody might want to enroll in Medicare Advantage. So virtually all enrollees are in a plan that offers vision, hearing, fitness, and dental benefits. And these are things that are not covered in traditional Medicare. And in particular for an aging population, but also for some people who are eligible through disability, these are important services. There are also over-the-counter allowances, so they allow you to go buy ibuprofen or things like that at a pharmacy, a certain, $200 a quarter or something like that. Meal benefits, usually following a hospital stay where you can get meals sent to your house. And then to a lesser extent, there are transportation to like medical appointments, bathroom safety, like grab bars in the shower, and then a rebate against your Part B premium that everybody pays. So if you see ads, this is something they'll call it like the give back benefit or money back in your Social Security check. Just under 20% of enrollees last year were in a plan that, or just under, 20% of plans are offering that this year. And then in-home support is one that's less frequently available, but some enrollees do have access to. And I'll add that it's almost always, or it's often without an additional premium. Since 2020, plans have been allowed to offer a certain set of benefits to people with chronic conditions. So generally, if they offer a benefit that's health related, it has to be offered to everybody that's enrolled in the plan. The special supplemental benefits for the chronically ill is a subset of benefits that do not have to be, though they can be health related, that are offered to only people with certain chronic conditions. For the most part, there aren't, plans don't offer a lot of these. We see some differences between special needs plans, which enroll either dually eligible people who are eligible for Medicare and Medicaid. There are some chronic condition special needs plans, and then institutional SNP plans, which has just pretty small enrollment. These SNP plans, as they're called in shorthand, do offer these benefits more often than individual plans, which are the ones that anybody can just go and enroll in during open enrollment. The more common benefits are food and produce, general supports for living, which include things like rent assistance or utility assistance, and then transportation for non-medical needs. Next slide. So this has come up a little bit already, but some trade-offs that matter most for people with serious illnesses and chronic conditions. First is prior authorization, and I'm going to go into this one a little bit more in the next couple of slides. But the prior authorization is a requirement that before your plan will pay for a service or a drug, that they must approve it. And this can create hassles and potential delays in getting care. Maybe in a best case scenario, a worst case scenario, it can actually lead to not getting care that your provider thinks you need. Denials. So when you're denied for something, it can be a hassle, and this relates to both prior authorization and payment. Few people appeal, but when people appeal, they're usually overturned. Network restrictions. I'm not going to go into this much today, but happy to answer questions. For the most part, Medicare Advantage plans include a provider network, and that can be a hospital network, a physician network, skilled nursing facility network. And so that means that you can only go to providers in that network, or if you go out of network, you either have to pay more, or if you're in an HMO, you may have to pay the full Medicare rate. You don't have a choice of formularies. So you might find a Medicare Advantage plan that you like, has a network you like, prior authorization policies you're willing to, you think you can manage. Then you have to go with the Part D coverage that's part of that plan. You can't buy a separate Part D plan. And traditional Medicare, you can shop for just your Part D coverage as a separate piece of your coverage. And then potentially higher out-of-pocket costs than traditional Medicare with supplemental coverage. So while those Medigap policies do have monthly premiums that can be, expensive, after you pay your premium, you have very low out-of-pocket costs. Medicare Advantage plans do have out-of-pocket maxes, but those are, $7,000. And so that can be quite a bit of money, and more than you would have paid if you had gotten a Medigap plan, depending on what types of services you're getting. Next slide, please. So going into prior authorization, we looked at data that CMS had published to look at how often were prior authorization requests being submitted on behalf of Medicare Advantage enrollees. And we found that on average, there are 1.5 prior authorization requests per Medicare Advantage enrollee for 35 million total requests in 2021. It ranged quite a bit depending on who the insurer of the plan was. So Kaiser Permanente had very few. Now Kaiser is a very different kind of organization that is integrated. They contract with Kaiser Permanente doctors, and they have their own facilities. But even United Healthcare had, somewhat lower, and then Anthem, Humana, Centene had much higher rates of requests, meaning that more services were subject to this process. Next slide. Then we actually sort of saw the inverse when we looked at how many were denied. So of the 35 million, 6% or 2 million were denied in full or in part, mostly in full in 2021. And for the most part, insurers that had more requests denied fewer of the requests. So we had Humana had a 3% denial rate, and Kaiser Permanente and CVS had a 12% denial rate. So all this is to say it does matter what plan you're in, and with 43 options offered by at least 9 insurers on average, it can be a lot for people to figure out when they're picking a plan. Next slide. So it's relatively rare for people to appeal prior authorization denials. Less than 10% overall were appealed. Again, that varied depending on the insurer, and we don't know exactly why the appeal rate varied, but you can see that 1% for Kaiser Permanente up to 20% for CVS. Next slide. And of that relatively small number that were appealed, the vast majority of those appeals overturn the initial decision. So 82% on average, but up to 94% for people in Centene plans. This could mean that most of the denials should have been covered initially. It could mean that only people who think they have the best case, actually file an appeal. Due to data gaps, we don't have any information about what types of services or the reasons things were initially denied. So it's hard to try to figure out what the reason is. But regardless, it's a pretty shocking number of rate of success. Next slide. And so one other thing I wanted to mention before I conclude is I sort of talked about in the beginning how many people were enrolled in this market, how many plans are being offered, and from a enrollee perspective, part of it is the access to extra benefits, not having to pay an extra premium for some of those benefits. From the insurer perspective, it does look like these plans are pretty important to their financial performance. So gross margins is one indicator of financial performance. It is the difference between the revenues, and in this case, it's mostly payments from the federal government, and costs, including expenditures on supplemental benefits. So I should say not all costs, healthcare costs. So your healthcare claims, and then vision, dental, those sorts of things. On average, in the Medicare Advantage market, the gross margins are, well over twice as high as the group market. So this is most employer-sponsored insurance or the individual ACA marketplaces. And while this isn't, exactly correlated with profits, because there's things like taxes and administrative costs, it does suggest that, they're doing pretty well, and this is an important part of their overall sort of health insurance market strategy. Next slide. And so I'm just going to conclude today by pointing out some gaps in Medicare Advantage data, which limit oversight and evaluation of program performance. So we actually came to do this sort of analysis of gaps because we've done a couple of literature reviews, both looking at Medicare Advantage versus traditional Medicare, and then specifically within the Medicare Advantage program, how it is serving beneficiaries of color versus white beneficiaries. And one of the most important takeaways we had from both of those literature reviews is just how little information is out there to really figure, even when there are dozens and dozens of research papers, they're very limited in the types of things they can look at, often because the data is not available. So for example, prior authorization requests, denials, and appeals by type of service. So an inpatient hospital admission, radiology or imaging, chemotherapy, those sort of like big buckets of service, that's not available. We don't know how requests, denials, and appeals vary by enrollee characteristics, whether that's race, age, dual status, whether somebody has a disability, whether they have other activities or limitations in activities of daily living. And then even within specific plans, so people choose a plan, but plans are combined into contracts. And what is reported to CMS is a very high level contract number of requests, denials, and appeals. So we don't even know within a contract if certain plans are requiring more prior authorization than others. As I mentioned earlier, we don't know the reasons for prior authorization denials. These are required to be, provided to the patient and also to the provider, but it's not aggregated by CMS. And so we can't do any kind of analysis to see, is it they're saying it's not covered, it's not medically necessary, certain paperwork or documentation wasn't submitted. So we just don't know. The share of Medicare Advantage claims that are denied after service has been provided are not reported to CMS. Out-of-pocket spending and other payment information for Medicare covered service is not published by CMS. So CMS does get some of this information from the insurers, but they do not publish it. And we don't know the characteristics of people the reasons, the disenrollment reasons by beneficiary characteristics. So CMS publishes, some high-level disenrollment statistics and reasons, but we can't say, are people who have a disability or are Black beneficiaries disenrolling or switching Medicare Advantage plans more often because they couldn't see the provider that they wanted to, or they had cost problems? Things that I think would help us understand how well Medicare Advantage is serving certain populations and whether there are differences, are things we just don't have the data to be able to evaluate at this time. And I will be happy to answer questions at the end. Thank you.
Thank you so much. That was so informative. I feel like I even learned a lot. I thought it was really interesting what you said about how much the federal government is spending on Medicare Advantage and kind of the lack of information the plans are kind of providing to justify that they're kind of entitled to these high costs, and they're kind of using this money that the government is spending on these plans appropriately. And so I think that kind of highlights a good opportunity to maybe say to the federal government, you're paying a lot for this. You have like a reasonable basis to ask for this additional data to be reported to know you're getting your money's worth, right? So I think that's definitely really interesting and really helpful for, like you said, helping us understand how these programs are working and impacting certain populations. I want to turn it over to Michael now, who's going to talk more about what are kind of the evolving cost-saving measures that we're seeing in the Medicare space, and what are some of the unintended consequences, and maybe where we can also be requesting some additional data be started to be included in these processes as they're evolving.
All right, well, thanks, Ashira, and just to provide a little bit of background on the Alliance for Aging Research. We're a patient advocacy organization based in Washington, D.C. Been around since 1986, and really we were started with kind of the impetus of increasing funding for research at the National Institutes for Health, especially around aging-related disease. Aging-related disease, including things like dementia, wasn't receiving a whole lot of funding at that time, so we've really been instrumental in helping those budgets increase over the years. And since then, our issues have really expanded to a lot of issues that touch upon the FDA, CMS, as well as the CDC around coverage, access, and value. So excited to build upon Jeannie's presentation and really talk about kind of some things that we see on the horizon, especially as really the biggest change to the Part D benefit that we talked about, the prescription drug benefit, since the advent of the program nearly 20 years ago is being installed right now with the Inflation Reduction Act. And so we can go to the next slide. The Inflation Reduction Act really has a lot of provisions, and both on terms of the federal spending side to help reduce spending on prescription drugs, as well as provisions that are beneficiary facing to help Medicare beneficiaries spend less on their medications. So for example, on the beneficiary side, starting next year in 2025, there's a $2,000 cap on out-of-pocket expenditures, as well as the ability for beneficiaries to pay cost under $2,000 and basically in zero interest payment installments. So CMS is working on how to roll that second provision out to beneficiaries to make sure that beneficiaries are able to opt into this option if they so choose. We're certainly seeing a lot of publicity from this around the $35 copay for insulin. Also already in place is an elimination of co-payments for CDC recommended vaccinations in both Medicare and Medicaid. And also not listed here is the Inflation Reduction Act expanded the low income subsidy program, often known as the Extra Help program. So beneficiaries that have lower incomes can enroll in this program to receive additional help in terms of affording their medications from the federal government. Now, on the savings side of the equation, to kind of partially to help pay for these provisions, as well as other provisions that were in the Inflation Reduction Act, which was a wide-ranging bill, which included, both healthcare provisions and non-healthcare provisions. But to couple of the provisions that were included were the Medicare Direct Negotiation Program. So this program allows the Medicare program to negotiate for the first time with drug manufacturers on the price of medications, to set a maximum fair price that the agency will pay, and then negotiate underneath that. So the first 10 drugs that are subject to that, negotiated prices will go into effect in 2026. And then, as I'll talk about in a few slides, there's really a larger redesign of the Part D program, changing who is responsible for what, whether it's a Medicare program, insurers, or manufacturers, who's paying. And I think that has a lot of potential impacts on kind of what we were just discussing in terms of incentives for plans to use different utilization management techniques. Next slide. So as just discussed, negotiation program, I think it's important to note that for 2026, it's 10 drugs in the Part D program, and 2027 it expands to 15 drugs, and then 2028 we see the program expand to the Part B program. So this program is going to grow over time and have a greater catchment of drugs that have high spending. I think what we kind of saw in the first 10 drugs at least is that sometimes although the prices for drugs, some of the drugs that were included are still challenging for some beneficiaries. It wasn't always like the eye-catching, eye-popping expenditures. A lot of it was kind of the drugs that are used by a lot of Medicare beneficiaries, things like direct oral anti-acting coagulants. So medications for cardiovascular disease, and so but I think it's important that this is the first time the federal government's negotiated directly with drug manufacturers. So it's going to be interesting to see kind of what side effects that unintended consequences we may see. Next slide. All right, and then I already covered this, so actually we're just going to skip forward again. I got ahead of myself, but I'm going to borrow from KFF here and talk a little bit about those changes to the Part D program. So this slide shows kind of the stakeholders that contribute to the cost of Part D drugs and the Medicare program, kind of who is responsible for what. And so we saw in 2023, and I'm going to hone in on this catastrophic coverage phase. So this is the coverage phase. Medicare Part D has multiple phases of the benefit, which are overly complicated, frankly, for 99% of the population. But in summary, catastrophic coverage, these are the individuals that have the highest expenditures in the program. And for example, this year the catastrophic phase kicked in at $8,000, and that's a combination of out-of-pocket cost and discounts that the manufacturer is offering. So it's not just what the beneficiary is paying; it has other costs involved too. So, but we saw in 2023 that the plan piece of this, the lighter blue piece, the Part D plans piece, was 15%, expanded slightly this year to 20%. But then next year, we see not just a step up, but we see kind of a huge leap for plans up to 60% of costs in this catastrophic phase. So what that really means in terms of kind of a cause and effect relationship is that previously there was a more limited incentive for plans to manage utilization more closely. I mean, there was still an incentive, but given that for these highest spending beneficiaries, Medicare was picking up 80% of the bill, there was somewhat less. But now that plans are going to be in the hook for Medicare Advantage plans, and PDPs are going to be tasked with covering 60% of this, they have a much stronger incentive to apply utilization management techniques. So next slide. And so as we're talking about, I know we discussed this a little bit before, but step therapy. So sometimes this is referred to as fail first, where you have to, your doctor prescribes you a medication, but then your insurer says that you may need to take another medication that may be less expensive first. You may have to go through multiple steps and have limited success in terms of your outcomes in order to move to the next step and to on those protocols. Prior authorization we've covered. Kind of, in a bigger scheme, though, I think that there's also the chance and the propensity for plans to maybe move drugs around on formulary. So, we may see more drugs move to, instead of kind of preferred tiers or kind of standard tiers, they may move to non-preferred or specialty formulary placements where beneficiaries on a per drug basis have a higher out-of-pocket cost. And then there's other types, which we won't go fully into, but copay accumulators and complex appeals processes. And so, I think when we're thinking about kind of what we just saw on the last slide, I think we are likely to see much, and frankly, I've heard, in just discussions around DC and among stakeholders that including those that are directly affected, that we are likely to see increased utilization management from plans, just as there's only so many levers for plans to kind of push, and kind of the language I've heard to help accommodate this additional spending. And so we are likely to see some of these tightened protocols. But I think in addition to kind of this Part D change, though, I think it's going to be interesting when we see in 2026, when you see the drugs that are subject to price negotiation, those prices go into effect. There's also kind of a complex interaction for how insurers and pharmacy benefit managers, who often manage the formularies for prescription drugs for plans, how they procure drugs. They often get rebates from manufacturers, which the PBM kind of often shares with their plan, and potentially other stakeholders on their side of the equation, but they get to keep part of that as well as savings. But then that often has an implication on where drugs may be placed on a formulary. And so with Medicare kind of setting a maximum price for these drugs, a maximum fair price, there may be less room for PBMs to negotiate these types of rebates, and so it may have an impact on what kind of rebates they receive. So there could be changes in formulary as a result. So I say all this, but I do want to note that there is that $2,000 cap in place, right? So if we're talking about like higher out-of-pocket costs per drug, we're still working towards a $2,000 cap, but it's really the access side that is concerning, especially when we're talking about things like step therapy, and looking towards like this upcoming year with that $2,000 cap. There's many beneficiaries that probably may have selected their prescription drug plan in the past due to having an out-of-pocket cap that wasn't offered in the fee-for-service program, or other kind of benefits that help them save money. But the plan that works best for them may change this upcoming year, because of that $2,000 cap. It changes the calculus for a number of beneficiaries, so we may see more beneficiaries switching plans than normal. But for beneficiaries that may have gone through something like step therapy or prior auth, where they've kind of jumped through those hurdles before, maybe they've taken other medications that didn't prove to be effective. When you switch plans, sometimes you have to, in the case of step therapy, restart that step therapy protocol. So you have to kind of go back and start from square one, or you have to appeal, to the point of what we discussed earlier, to get the therapy that your physician believes is most appropriate for you and may have worked in the past. So I think that there's some unique challenges that beneficiaries are going to need to be aware of heading into open enrollment. Going to the next slide. So there are some things that Medicare could be doing in the interim to help kind of protect beneficiaries during this transition period. The first is just creating guardrails. I would say even just expectations of plans, setting clear expectations of plans. We're going to see increased utilization management, but the protocols need to adhere to best practices, the clinical guidelines. That needs to be the justification rather than, and CMS needs to require robust justification rather than it just being due to the plans being under increased financial pressure. And so I think kind of that proactive approach is what, from the patient community that we're hoping to see. And then we want to ensure that, that plans just continue, that we don't see huge changes in formularies overnight just because of the impact of the law, that we are just really keeping the patient at the forefront of everything that we're doing in our healthcare system. And so, so there's a couple of other things here, but I want to make sure that we leave time for Q&A. So I want to thank everyone for your time today.
Thanks so much, Michael. I think that's really helpful in highlighting, especially the cap and the $2,000 limit, what that's going to be, and how it may change people's position on how they think what plan is best for them. And it kind of reiterates the importance of making sure that if more individuals are going to be enrolling in those Medicare Advantage plans, they're going to be working to the effect to best help the beneficiaries, right? And they're not going to be subject to all these additional protocols that they weren't expecting when they were trying to benefit from this new limit. So like you said, with that, I want to turn it into our panel discussion, and we'll also open it for the Q&A at this time. So if anyone has any questions, feel free to drop them in the chat, and then I will address them. I think my first question is going to be for you though, Michael. I think what you talked about is kind of a lot of these like changes that we could be expecting to see with these changes in the catastrophic coverage requirements. What kind of data, and maybe this is for Jeannie as well, do you think we should be asking CMS to require these plans to report about how they're using step therapy or how they're using prior authorization, so we make sure that it's not impairing access?
Yeah, I mean, I think part is just kind of transparency around their data they're receiving. So, I mean, there's going to be a data lag, right? Like we're not, CMS is not going to see these problems instantaneously, if patients are having access issues. So, I think it really would be helpful to understand not only, on kind of a relatively as real-time basis as possible, are we seeing how many changes in formularies are we seeing? What is the volume of appeals picking up? Those types of things I think can be indicative of larger challenges that we may be facing. Certainly I'd love your team to weigh in as kind of the expert, since I'm already using your data in my slides. So I'll turn it over to you.
Well, so each year, Part C and Part D plans have to report they call it like their determinations and reconsiderations data. And right now, and they do that for both prescription drug claims and then anything Part A and B, but it's just one number for all of the services that fall into that bucket. And so we don't know, I think there's a lot of different ways they could, or detail that could be asked. So beneficiary characteristics, the diagnoses that was related, the particular service or even class of drug, just a little bit more detail. And I know in some, CMS is sometimes wary of having too much information for beneficiaries, but there's already too much information out there and not all of it's useful. So some of this would be useful to people who are, conducting oversight of the program, and, could potentially be aggregated into something that could be helpful for beneficiaries as well when they're making decisions.
Yeah, and I think that's helpful. And I think even just on Medicare Advantage Plan Finder, like in that Plan Finder tool, like as you kind of walk through that tool, you can go in and see if the drugs that you're currently taking or may feel like you may take in the future are covered by the plan that you're considering. However, there isn't a whole lot of insight into the types of utilization management that may be subject to, understanding whether it's a prior auth thing and it may be more manageable compared to step therapy protocol, which may be more challenging. So even beneficiaries having that type of information at the point of selection of plans, I think makes sense from a beneficiary perspective, and also just from a transparency perspective, and ensuring that plans are competing, not just on cost, but really on the amount of access they provide as well.
That's really helpful. Yeah, like I think you both said, I think it's important to make sure that the data that we're getting is useful data, and it's not just kind of checking the box and saying we have this bulk of data, but having enough information about the data to make sure that we know what the gaps are in these programs and how they can be filled and be more robust for consumers. So Jeannie, I know you said there's a lot of differences within MA and traditional Medicare in terms of benefits, prior authorization processes. Do you see from the data that there is improved outcomes from individuals enrolled in Medicare Advantage compared to traditional Medicare? Do we need more data for that? If so, what type of data do we need?
Yeah, so both traditional Medicare beneficiaries and Medicare Advantage enrollees are on like well over 80, close to 90%, depending on the year, report that they're satisfied with their health insurance coverage. So beneficiaries are reporting that they are satisfied. When we look at outcomes, there's not a lot, but Medicare Advantage plans do seem to do a little bit better at providing preventive services. People do have higher rates of getting some preventive services, vaccines, screenings when they're in a Medicare Advantage plan. That is about, I think, one of the only ones where there is really maybe a clear difference. Some of it, is because we don't have reliable data. Plans do have to report some information in their encounter claims so we can see utilization, but there has been questions about the quality of that data. It's also very difficult to compare to traditional Medicare, in part because of this coding issue. People look sicker in Medicare Advantage than somebody who is of the same health status looks in traditional Medicare. So it's hard to say somebody of the same health is doing better or worse than Medicare Advantage because when we collect diagnoses, it sort of muddies that comparison. Yeah, I think overall we don't have very much information. We know people are happy in both generally. Medicare Advantage enrollees do report slightly higher rates of cost-related problems than people in Medicare with supplemental coverage. So people who can, which is most people in Medicare, traditional Medicare, if they have a Medigap policy or Medicaid, they report lower cost-related problems than people in Medicare Advantage.
Okay, that's helpful to know. I know when we're looking for changes to the Medicare programs, it can be challenging, obviously, because we're dealing with, like you said, different populations, different conditions, different diagnoses data. Michael, do you think there's any kind of lessons learned from the commercial or the ACA markets that we can bring over to the Medicare programs to kind of improve access for patients to medications, or just how they benefit from these programs?
Yeah, I mean, I think it's kind of interesting in that the Medicare program and the MA program, in terms of like these access issues, I kind of alluded to it, but there really have been fewer kind of instances of people reporting. I mean, it's been, there are certainly issues and people have cases where they have challenges receiving what they need, but it's very different than in the commercial population. And so I know even there's legislation moving to try to, it's been under consideration to help bring kind of the understanding around, step therapy and things like that in the commercial market closer to the kind of standards and appeal systems that we have in Medicare. And so, but now that we're seeing the system kind of with these changes under effect, I think we're going to see kind of it's a little bit of a stress test for it to see if it's really the protections that we have in Medicare are enough. And so really, as we kind of think more broadly, we just need to make sure that we do have transparency into the data, the beneficiaries have the data that they need, both from the data that CMS is providing and those in the nonprofit sector like KFF and others that do this great data work to make sure that we're really making informed decisions.
Yeah, definitely. I think the biggest thing I'm hearing from both of you is that it can't be like, we've checked the box, we've got the data, we have to continue to collect data, allow it to be robust, and allow the requirements for the type of data that we have to have disclosed evolve with the needs of these programs to make sure that they are continually approving for beneficiaries. But we are almost at time, and I just wanted to highlight for everyone attending today, there is currently an RFI opportunity to comment to CMS on the type of things that they should be collecting data on. So whether you are a data expert like Jeannie or an advocacy organization like Michael and myself, this is a great opportunity to highlight these considerations, like they should be tracking how step therapy is being used, how prior authorizations are being used, why there's a 90% approval when you appeal a prior authorization denial, things like that. So even if you're not an expert in data, this is a great opportunity to put at the forefront of CMS's view the things they should be considering as these programs are evolving. And just Michael and Jeannie, thank you both so much for your participation today, and it was a really valuable conversation.
Thank you.
All right, thank you.
Thanks.